Welcome, everyone. Thank you for joining our second session for bronchiectasis advancements as part of CHEST. We thank CHEST and organizers, and we thank for the speakers for dedicating your time and your passion towards education. And hopefully, our audience will find this informative and educational. I am Nauman Chaudhary. I'm professor of medicine at Virginia Commonwealth University. I'm director of the Adult CF Center.
Hi, everybody. I'm Chetna Penkar. I am the Director of Pulmonology at Bellin Memorial Health in Green Bay, Wisconsin. I'm a community pulmonologist with a special interest in bronchiectasis. I'm also an adjunct assistant professor at UWGB rural campuses here in Green Bay.
Hi, everybody. Nauman, thanks for having me. I'm Dr. Devarajan. I'm a pulmonary critical care physician at Baylor College of Medicine, where I focus on non-CF bronchiectasis, cystic fibrosis, and medical education.
Thank you for having me. My name is Malvika Kaul. I'm an assistant professor of clinical medicine at the University of Illinois, Chicago, where I'm part of the educational leadership of the fellowship program, and my special clinical interests are airway disorders and bronchiectasis. Thanks for having me.
Thank you, and welcome everyone again. My first question for my first speaker would be Dr. Penkar. How do you recommend screening for bronchiectasis in people with obstructive airway diseases such as asthma and COPD? Is this considered a disease progression of these diseases or a different phenotype among these patients?
Thank you for that question, Dr. Chaudhary. So I would like to set the record, straight. First of all, bronchiectasis is a separate entity from any of these obstructive airway disease. And, even though there are overlapping features, having bronchiectasis by itself has a very different effect on the clinical course of the patients with the asthma and COPD. Now come to the question of who should be screened for this COPD, in your COPD and asthmatic patients. I would say patients who have, frequent exacerbations, more than two per year, daily sputum production, recurrent infections such as Pseudomonas, NTM, somebody with unexplained hemoptysis, hypoxemia, unexplained sudden decline in lung function would be somebody that you would get a CT scan for. And then on the CT scan, you would basically be looking for, your classic airway to artery ratio more than 1, lack of tapering, bronchi present near the pleura. Now, if you go back, to the original question, with Dr. El-Youssi et al., Yousini et al., what we realize is bronchiectasis is present in almost 17% of the patients with COPD and can significantly amplify complications such as hemoptysis, hypercapnia, or, bacterial colonization. Other studies, but, Dr. Martinez Garcia, where they studied the BCOS or the bronchiectasis COPD overlap syndrome, what we realized is they're associated with much increased levels of bacterial colonization. They have more inflammation, more frequent exacerbation, as well as increased hospital visits. Now coming to the part where we have asthma and bronchiectasis, what we've realized is severe eosinophilic asthma or ABPA associated phenotypes. Bronchiectasis is an often under-recognized contributor for the mucus plugging, for the airway remodeling, and poor disease control. So just to summarize it, I would say, identifying bronchiectasis in these patients fundamentally helps us shift the management strategies to incorporate more airway clearance techniques, chronic macrolide therapy for control, and then routine microbiologic surveillance. And then, if you see a tough to control obstructive airway patient, then we should think bronchiectasis is how I would like to leave this question. Thank you.
Thank you, Dr. Penkar. That was very, very nice and very informative to screen those patients among those big, large cohort and look for the overlap syndromes as well. My next question is for Dr. Kaul. When do you recommend using inhaled antibiotics for Pseudomonas aeruginosa in bronchiectasis patients?
Yeah, thank you for the question. And I think a good start to answer this question is why Pseudomonas is important in bronchiectasis patient. We know from med school and microbiological knowledge that Pseudomonas is a very virulent organism. It forms these biofilms and it's hard to eradicate. Especially in bronchiectasis patients, it's not merely a bystander. Usually it's a prognostic marker in itself and causes a lot of problems in these patients, including increased frequency of exacerbations, lung function decline overall, reduces quality of life, and increases mortality. And it's included in a lot of these prognostic scoring systems of bronchiectasis. So knowing that that's a really important thing to treat and recognizing it early and acting on it fast is important. And then the second portion of this is that inhaled antibiotic part of it. It makes mechanistic sense why you would use inhaled antibiotics in bronchiectasis and Pseudomonas infection, because you are basically delivering a high quantity of these antimicrobials to the lungs directly as compared to more of a systemic reach. So there's more, especially people who have more disease burden, people who have more bacteria in their lungs, this would act more. So it makes sense in that way. To answer the question directly, the three main reasons that you would use these antibiotics, inhaled antibiotics in Pseudomonas, number one would be for eradication therapy. So that first isolate of Pseudomonas that you get in a patient is important to recognize and treat. And that usually includes kind of a combination of systemic, oral, or IV antibiotic with this inhaled. The first one for 2 weeks for the inhaled or oral, and then the 3-month course for the inhaled antibiotic. And the reason for that is you want to act fast on it because this bacteria is hard to clear and can form those chronic infections. In studies, it's shown to be cleared about 40% of the patients if you use this eradication therapy to clear. So if you are a person who sees the glass more half than full, then 60% don't. So you have to let the patients know that if you're treating them, there's a chance that they might not get eradicated. The second reason that you would use these antibiotics would be if they had that chronic infection, those who basically have 2 or more sputum production at least 3 months apart within a year, persistently positive for Pseudomonas. They have, to reduce their bacterial load, to airway inflammation, reduce the exacerbation rate, you can use these inhaled antibiotics as well. And the last one is those frequent exacerbators, which is there in the guidelines, specifically the European guidelines, the British Thoracic Society and the European guidelines that they mention. If you have 3 or more exacerbations kind of within a year with Pseudomonas, inhaled antibiotic treatment is recommended for those. And then also in those guidelines, if someone who doesn't have Pseudomonas and has been treated with macrolide therapy and are not responding, can give inhaled antibiotics to them as well. In United States, we sometimes, in clinical practice, actually even use it if it's 2 or more. So not necessarily always following the European guidelines, but that's what the guidelines state. The common antibiotics that are used in the United States and the most readily available is tobramycin, inhalation or dry powder. And it's used kind of twice a day. There are other antibiotics. Colistin is another one that is used. That's more readily available in the UK than here. Here it's kind of in a more IV preparation that is given in nebulized formations, but not like a direct nebulizer available. And then other drugs like aztreonam, gentamicin, and amikacin, which is also used in NTM disease, is also available. When you're giving these inhaled antibiotics, it's important to also know what kind of side effects they have. So people usually get bronchospasm, sometimes cough, taste change in taste. So it's important to know those things. And lastly, I want to kind of end the discussion with the evidence behind it. Now we have these inhaled antibiotics available, and most of the literature comes from cystic fibrosis patients, and it's FDA approved for those. And there's clear indication that they reduce exacerbation, lung function, improvement and quality of life in those patients. But unfortunately, the most disease population I see is non-CF bronchiectasis, and in them, to date, at least I don't know that there is no FDA approved inhaled antibiotics for those population. The reason for that is the data overall is mixed for these patients. There are some studies that have shown higher bacterial eradication, reducing the exacerbation rates, but the data is just mixed. And I think the big reason for that is because the non-CF patients specifically are very heterogeneous. So including a heterogeneous population in these clinical trials, kind of expect to have those mixed results. So because of all of this, there is issues with insurance hurdles getting these medications for these patients, and just that non-FDA approval gives big problems. And then medications like colistin, they need compounding pharmacies, and that it can be a hard access for the providers and patients overall.
That was fantastic. It was very detailed and very thorough and covered a lot of depth of information and years of data, as you mentioned. Yeah, I think as you gave a lot of practical hint points, and I agree in practice, if we use more airway clearance and aerosols prior to inhalation of antibiotic, perhaps we can minimize some of the side effects that some people bring up and you mentioned as well. Thank you. My next question is coming back to Dr. Penkar. That is addressing how do you recommend managing immune suppression in rheumatological diseases where chronic colonization with non-tuberculous mycobacterium and gram-negative organisms may be present? Drugs, particularly such as steroids and biologics, which can possibly make those infections worse, and very clinical practitioners to utilize some of these therapies.
Thank you so much for that question, Dr. Chaudhary. I actually, in fact, had a patient in clinic like 2 patients ago where I had the exact situation. You know, what do you do when you have a patient who has like either rheumatoid arthritis or vasculitis and they have bronchiectasis, and now you have a problem on your hand, and then they need immunosuppression, but their sputum is positive for NTM and Pseudomonas, and what now? Like, we have to balance the risk between immunosuppression as well as the risk between the progression of the infection. And I think we need to start as risk stratification. And, you know, after ensuring obviously vaccination is up to date and ensuring that they don't have any other immune dysfunction, which for my current patient had CVID when I looked for it, you know, would be the next thing would be to kind of figure out with, you know, a sputum cultures, with CT scan, with PFT as to, you know, where they are with respect to this bacteriology. Is it just a colonization? Is it an active infection? So on and so forth. So if there is no active infection and there's just bronchiectasis, again, you know, just diverging a little bit from the main question, we can progress with immunosuppression, but, you know, it's with caution of, you know, getting regular sputum cultures, probably 3 to 6 months, and optimizing airway clearance is going to be the bottom line for all these patients, right? Just so that we are improving their chances of not getting the infection. Second part would be if they're chronic colonizers, you know, obviously high dose steroids or, you know, prolonged steroids would obviously put them at a higher risk. And in that situation, you know, we would monitor them, but progress with caution about escalating immunosuppression. And then we can use some lower risk biologics over, you know, the TNF alphas, because we know that there's a relative higher risk when it comes to airway specific infections. We can also think about suppressive therapies. And then that gets me to the team approach, where certain patients which have the cohort of diseases that we are talking about, we have a cohort of practitioners with rheumatology, pulmonology, infectious disease, kind of working in synchrony to come up with the best plan. If there is a patient with active infection, obviously, I would say we should defer the immunosuppression, treat the infection, kind of get a control over the infection, and then resume immunosuppressive therapy once the infection is a little bit more controlled. Some of the key factors would be, you know, trying to choose the immunosuppression therapy that's the least chance of progression of certain infections. And then just going back to the basics, multidisciplinary approach, having everybody that's a stakeholder in this patient's treatment communicate with each other so as to, you know, have that sequence of therapy, like treat infection, reintroduce immunosuppression, and then tailor the patient's treatment to that autoimmune infectious component simultaneously. Thank you.
Thank you very much, Dr. Penkar. That was very nice. And interestingly, bronchiectasis patients, just like CF patients, are able to contain those infections to their lung. It really becomes a systemic infection like typical immune compromised or septic patient we see. So they don't really, become bacteremic or septicemic. And as you mentioned rightly, picking up your patients and trying to optimize their therapy can help it out, and some more learning to do there, perhaps. Next question, I think, would be for Dr. Devarajan. Uh, when will you consider biologic therapy in patients with bronchiectasis and allergic bronchopulmonary aspergillosis?
Yeah, Dr. Chowdhury, that's a great question. Well, I think the first thing I would say is that I do consider biologics in these patients. And when you look at sort of biologics, there has been a little bit of a mission creep. They were originally kind of created for severe asthma control in patients with refractory disease. And we've seen a really, really broadening of that literature and much more endotype-based asthma treatment that is now starting to move into the COPD category. And you're seeing a lot more sort of targeted endotyping of COPD patients as well. And as we know that, they're, taking into account what Dr. Benkar said is that, bronchiectasis in many ways is of course its own disease, but it is a common endpoint to multiple diseases, immune suppression included, or chronic infection included. But we do know that there are certain types of asthma, a la, severe asthma with ABPA, or severe COPD with, let's say, prior MAC infection, where patients can develop bronchiectasis. So you can see these syndromes sort of overlap. And what I would say is that biologics for bronchiectasis specifically is not very fleshed out. Most of the data is still very much in case report, case series format. We are really lacking randomized control trials for this, although there are efforts being made to make that happen. But it is challenging because, as Dr. Gall had mentioned, this is a very heterogeneous disease. So to me, biologics in bronchiectasis, just like most of the interventions that we provide in medicine, patient selection is really, really important. And so in the setting of ABPA, for example, right, we have a great swath of literature now. Some of the most compelling data comes out of India, actually, when, in the RCTs in azoles versus corticosteroids. And we know that both, systemic steroids, which are kind of the gold standard for ABPA, has a lot of side effects, and especially in patients with, metabolic syndrome type comorbidities like diabetes. And then not to mention the fact that, systemic steroids taken over 2-3 months to treat ABPA and bronchiectasis brings along a lot of immune suppression, which can lead to a multitude of complications, infections included. On the other hand, azoles, which are more appealing in that sense, is that they have less side effects. They are not without their side effects. There's a lot of medications interactions. They prolong the QTC in patients who, even with patients with normal EKGs, let alone patients who are on multiple medicines that could make that worse. So to me, patient selection really matters. And so my bias is always to usually start these patients on systemic steroids to see if they have a nice response, and see if there's a way we can transfer them over to azoles for a certain period of time, whether that be 2, 3, 6 months, depending on clinical response. But if you have patients with refractory ABPA, for example, or patients who cannot tolerate corticosteroids or antifungals, I think biologics are an option, especially in those patients who have clear, sensitization, fungal sensitization, right? They've got peripheral eosinophil elevation. They've got high IgEs. They have specific IgEs that are elevated, or their skin tests are positive for sensitization to aspergillus or a different type of fungal sensitization. That would be sort of my take on it, is that I think that before moving to biologics, I think we go through what the evidence shows is the most effective treatment for ABPA, which is steroids with or without the use of antifungals.
Thank you, Dr. Devarajan. That was very fantastic answer and very helpful. Sometimes we come across drug interactions in CF patient populations, particularly with highly effective modulators, and with azoles having those interactions and requiring reduction in the dose of modulators also makes us consider biologics possibly. So that was very informative, and thank you. Next question is coming back to Dr. Call. What is the role of sputum cultures in bronchiectasis? Is there a connection between sputum culture and microbiome?
Yeah, I think the short answer is sputum cultures are definitely essential in bronchiectasis, but it's kind of just a part of that big story. I think it gives a nice snapshot of what the prominent bacteria are in that bronchiectasis patient, specifically identifying key pathogens that have that issue with risk stratification, like having prognostic implication, basically. So like I talked about before, Pseudomonas, and then the sputum cultures help to guide antibiotic therapy in those patients. But even though the sputum cultures are there, I think airway microbiome is a little bit more granular detail for what different organisms that exist in that environment. And then with more advancement like sequencing techniques, we have now identified the different organisms in that microbiome. And microbiome identification basically means, rather than identifying that individual pathogen, identifying the diversity of that microbiome. Because it's seen that if you have low diversity, it's called low alpha diversity, and specifically for organism structures like proteobacteria, which include Pseudomonas and neutrophil bacteria, they have those patients have more exacerbation, poor quality of life, and increased mortality. This also is an emerging, I think, clinical tool to identify those endotypes, like we talked about, since bronchiectasis, like we kind of seen by now, it's especially the non-CF ones are a very heterogeneous population, and this has emerged now as a clinical tool to identify those endotypes and eventually guide kind of therapy. A good example also understand why microbiome is important, because there's a concept called quorum sensing, in which these bacteria that are kind of low abundance, they regulate virulence and biofilm formation of the bacteria that are around them. For example, I'm sure a lot of people that are here have had patients who come in with an exacerbation or flare-up of some kind, and you give them some antibiotics and they become better, and then Pseudomonas or something presents in their culture, and you haven't actually treated them for that, but they become better. So the quorum sensing in that part makes sense, that you're suppressing those other bacteria that might be kind of indirectly causing increased virulence of the other organisms. And then, as I said, it's an emerging clinical tool. So identifying that endotype, as well as maybe finding non-antibiotic strategies for patients, like probiotics, immunomodulators, or things that are being explored. And then biomarker development is another thing that I think the airway microbiome has opened up that chapter. And there's a recent paper by Dr. Chalmers from the UK, their group in CHEST in May 2025, that looked at what are the biomarkers and IgA antibody in the serum for NTM pulmonary disease. And they found that this particular biomarker was pretty sensitive and specific for NTM pulmonary disease as compared to people who just have NTM in their lungs with no pulmonary disease or no NTM at all. So overall, I think sputum culture is a valid and vital thing that we have to do with our patients, and that gives an idea of those dominant pathogens. But the sequencing-based microbiome profile adds to more prognostic value and kind of mechanistic insight for these patients.
Thank you, Dr. Call. Yeah, there's a lot of research going on in the microbiome era, and some more learning to do there. Thank you. And my last question is coming back to Dr. Devarajan, similar theme. How do you approach fungal infections on sputum culture and bronchiectasis?
Thanks, Dr. Chowdhury. That's a tough one. I think, having done this for a while now, that I feel like the majority of the fungal cultures I get in these patients generate some kind of fungus. Very often yeast comes up, Candida species, for example. And, it's very interesting. There's a lot of, obviously this could be a consequence of simple inhaled steroid use, where, in bronchiectasis, really, we should be trying to avoid inhaled steroid use, but we know out of the data coming out of Europe that like the majority of these patients are on inhaled steroids. And I think that the BRR registry data supports that as well. So I think it's one of those things where, it's very common, I think everybody should know, in patients with bronchiectasis in whom you obtain fungal sputum cultures, it's very typical to see a positive culture come back. And the vast majority of the time, this is going to be simply a finding and not something consequential. So if you catch Candida albicans or Pallisolopsis or glabrata, There's actually nothing you really need to do with that information. The trick, sometimes you'll pick up an aspergillus, fumigatus, or Niger, or Terrius, and what does that mean? So I'm more interested when I find aspergillus mold in sputum, but only to an extent. So if you look at ABPA, which we talked about a little bit earlier, if ABPA, there's many different criteria out there, but the original kind of criteria, the Rosenberg-Patterson criteria from the late 70s, did include fungal culture isolation of mold as part of their criteria, but it was a minor criteria, and it has very poor sensitivity and specificity for diagnosis of ABPA. And so I think one of the big take-home messages is just because you find aspergillus on the sputum does not equate to someone needing treatment for that aspergillus. And just to kind of carry home this point, the ISHAM group, which actually put out updated guidelines in 2024, really didn't include fungal isolation in sputum as part of their criteria for ABPA. I think the real question, if you find something like aspergillus species, for example, on a sputum sample, is going to be, okay, in my patients with bronchiectasis, what is their clinical status? Because if they're very, very stable, then essentially this is just additional information about the microbiome. And, we know that they have an aberrant microbiome, these patients. But if that same patient in whom you isolate this mold is somebody that's been exacerbating very, very frequently, despite usual controller measures such as antibiotic therapy, inhaled antibiotic therapy, use of airway clearance, trying to address comorbidities like asthma, GERD, allergic rhinitis, chronic sinus disease, if they're still exacerbating, I think if it's not already been done, this is a good opportunity to sort of endotype that patient. What's the serum IgE, what total IgE, what are the specific IgEs for these different mold isolates? Do they have peripheral eosinophilia? And if those things come back positive, then you do start building a case for maybe more of a fungal airway sensitization or an ABPA picture, which would necessitate a treatment switch. But I would say fungal culture isolation of a mold in and of itself, in my experience, has very, very little value.
Thank you so much, Dr. Devarajan. Thank you to all the speakers for coming together and putting a great webinar for our audience. I'm sure everybody will feel and find it very educational, informative, and I hope that if audience likes it, they give us a thumbs up, and so that we can continue with our future recordings and continue to bring practical short bites format tips in this kind of webinar for the future. And thank you to all the CHEST organizers as well. I appreciate your time towards this recording. Have a great day.